In clinical practice, informed consent stands as one of the fundamental pillars of the doctor-patient relationship. In essence, it represents respect for patient autonomy, that is, the patient's right to decide on procedures that affect their body, their health, and their life. But as we well know, medicine does not always unfold under ideal conditions. There are situations where time is of the essence, the patient cannot speak, family members are not present, and life hangs in the balance. In these types of exceptional scenarios, informed consent does not disappear. Rather, it is momentarily suspended, giving way to a legal and ethical concept that we will analyze in this class. Therapeutic privilege. This legal figure authorizes medical personnel to intervene without prior authorization. It applies strictly when the patient cannot make decisions for themselves, there is no one available to represent them, and any delay in care would imply serious harm or even death. Throughout this session, we will examine exactly what this privilege consists of. We will look at its regulatory foundations, the criteria that must be met for it to be valid, how to document it correctly, and above all, the limits that must never be crossed. We will also review specific examples involving both adults and minors, because although the general principle remains the same, the legal and ethical implications can vary significantly depending on the patient's age. A crucial note before we begin. The cases we will discuss here are merely illustrative. In the book, The Art of Medicine Within the Framework of the Law, El Arte de la Medicina en el Marco de la Ley, this topic is developed in much greater detail, including real-world examples, complete legal references, and deeper analysis. Here, our goal is to introduce the topic and focus on the essentials required for daily medical practice. Therapeutic privilege is an exception to informed consent, but it must never be confused with irresponsible omission. It is a specific legal and medical concept that allows intervention without prior authorization only when the situation genuinely demands it. This resource applies under specific conditions, when the patient cannot express their will, such as in cases of unconsciousness or altered mental state, when no family members or legal representatives are available, and furthermore, when time is critical, meaning that delaying the intervention could have fatal consequences. It is not a mechanism activated for convenience or presumption. Simply because a patient hasn't signed a form is not enough on its own. There must be a clear medical justification, a supporting clinical context, and evident urgency. And here is a crucial point. Even though the action is taken without prior consent, the medical act must be documented. This includes the date, time, reason for intervention, diagnosis, procedures performed, and all evidence justifying that decision. This documentation need not be done before the procedure, but it must be completed as soon as the patient is out of danger. The General Health Law establishes this possibility. Article 51 bis 2 states, and I quote, "The health service provider shall proceed immediately to preserve the life and health of the user, leaving a record in the clinical file." This gives us a clear legal framework, but it also imposes obligations. Therapeutic privilege is not discretionary permission. It is a legally backed medical response to an urgent clinical necessity. For therapeutic privilege to be valid, the existence of urgency alone is not enough. A series of conditions must be met simultaneously, and it is essential that the healthcare professional is able to recognize and document them. First, there must be a real medical emergency. This means a situation involving an imminent risk to the patient's life or integrity. We are not talking about a potential or doubtful risk, but a scenario that demands immediate intervention. Second, the patient must be incapacitated to make decisions. This may be due to unconsciousness, acute neurological alterations, or conditions preventing free and reasoned consent. Important, if the patient is conscious and oriented and simply has not signed a piece of paper, we are not dealing with a case of therapeutic privilege. Third, there must be no family members or legal representatives available at that moment. It is not enough that they are difficult to contact. It must be demonstrated that it is impossible to wait for their authorization without putting the patient at risk. Fourth, the medical decision cannot be made individually. The treating physician must have the backing of at least one other authorized physician. This is established in Article 81 of the Regulation of the General Health Law, which textually states, "The authorized physicians of the hospital with the agreement of at least two of them shall carry out the therapeutic procedure, leaving a written record in the clinical file." Now, who exactly are these authorized physicians? The regulation does not expressly define this, which has led many institutions to establish their own internal criteria to provide clarity and operability. Generally, figures such as the medical director, the assistant director, or the head of the emergency department are designated, provided these positions exist and are available. But what happens outside administrative hours or in hospitals lacking this hierarchical structure? In such cases, it is recommended that every hospital have a clear institutional policy determining a sequence of substitution. If the director is absent, another physician from the same service, the same specialty, or an attending physician with sufficient experience may intervene. The key is that this decision must not be arbitrary. It must be backed by defined and consensual criteria, and it must always be recorded as part of the clinical file. This protects not only the patient but also the healthcare staff intervening. Finally, everything must be documented in the clinical file. This includes the patient's status, the urgency, attempts to locate family, the second physician's opinion, and the details of the procedure performed. This last point is reiterated in the General Health Law, Article 51 bis 2, and in the Regulation, Article 81. To quote the latter again regarding the documentation, the authorized physicians with the agreement of at least 2 of them shall carry out the procedure, leaving a written record in the clinical file. If any of these elements is missing, therapeutic privilege is not justified. I want to note that the book analyzes intermediate scenarios and what to do when some of these points cannot be fully met, such as in rural zones or during night shifts without immediate availability of other doctors. When we discuss therapeutic privilege, we are not just talking about a legal exception. We are entering a delicate zone of medical ethics. Here, a clinical act has the potential to save a life, but it also has the potential to transgress, even if temporarily, a person's will. We must ask the hard questions. To what extent is it ethical to intervene without consent? When is it truly justifiable? And when might it cross the line into excessive paternalism? It is a balancing act. Applying therapeutic privilege implies suspending the patient's autonomy, even if only for a moment. This can only be done if we act based on the other core principles of bioethics: beneficence, non-maleficence, and justice. Beneficence drives us to act to save the patient's life. Non-maleficence reminds us that failing to act can also cause harm. And justice demands that our decisions be coherent, equitable, and applied with the same criteria to all patients without discrimination. Therefore, this concept cannot be used capriciously. It cannot become a routine resource. It demands that clinical judgment be accompanied by a deep ethical conscience. Before acting, the physician must ask themselves, am I doing this for the patient's good? Do I have a real medical justification? Am I respecting their dignity even in this situation? And above all, we must avoid paternalism. We must reject the old idea that the doctor always knows best. Therapeutic privilege does not grant power, it grants responsibility, a responsibility that must be exercised with humility, with clinical backing, and with full awareness of its limits. When we speak of pediatric patients, informed consent becomes more complex. This is because minors cannot grant it themselves. Generally, the decision falls upon those exercising parental authority, patria potestad, or legal guardianship. But we must ask, what happens when there is an emergency and the parents are not available? Or worse, what happens when they are present but refuse to authorize an intervention that is necessary to save the minor's life? In these cases, therapeutic privilege can also be applied, but with additional precautions. First scenario: absence. If no responsible adults are available and the urgency is evident, the medical team must intervene, provided there is an agreement from at least one other authorized physician, as indicated by Article 81 of the Regulation of the General Health Law. Second scenario: parental refusal. If the parents are present but oppose the treatment, the physician cannot simply dismiss their decision. Institutional protocols must be triggered. This generally implies notifying the DIF, System for the Integral Development of the Family, or the Public Prosecutor's Office, justifying that the intervention is indispensable to protect the minor's life or health. The legal basis is strong. The Mexican Constitution, in its Article 4, clearly establishes that in all actions of the state, the principle of the best interest of the child, interés superior de la niñez, must be fulfilled. Furthermore, the Convention on the Rights of the Child reaffirms that the minor's well-being must be the priority in any decision involving them. The conclusion is clear. When a guardian's refusal puts the minor at risk, health institutions are obligated to intervene to protect the child, even if that means acting against the will of the parents. However, a warning. This intervention cannot be arbitrary. It must be strictly justified, fully documented, and, if time permits, institutionally backed. A note on further learning. In the book, you will find detailed examples of these cases, analyses of complex scenarios, and proposed institutional strategies to handle these situations in an ethical, legal, and careful manner. Let us now look at a representative case. Simple, yet highly illustrative. The scenario. A 35-year-old male arrives at the emergency department following a car accident. He is unconscious, carries no identification, and has no family members or contacts available. He shows evident signs of internal hemorrhage and requires urgent surgery to save his life. The dilemma. In this scenario, the treating physician cannot wait. They cannot waste time searching for someone to authorize the procedure, nor can they pause to fill out forms. The patient's life hangs in the balance. The appropriate course of action, under the current legal framework, is as follows. First, the physician performs an immediate clinical assessment. Next, if time permits, They consult with another authorized physician to endorse the decision. And finally, they proceed with the surgical intervention immediately, without waiting for a signed consent form. The documentation. Once the patient is stabilized, a detailed record must be entered into the clinical file. This must include the date, time, diagnosis, the procedure performed, the specific reason for acting without consent, and the endorsement of the second physician. Legal backing. This is not only permitted, it is legally backed. Article 51 bis 2 of the General Health Law states that, in such cases, the health service provider shall proceed immediately to preserve the life and health of the user, leaving a record in the clinical file. A crucial lesson. And here, it is vital to reinforce one point. The obligation to document is not a prerequisite to care. It follows it. The priority is to save the patient's life. Recording it comes second. Life cannot wait for a signature. This second case is particularly sensitive. It represents a situation that, while seemingly extreme, occurs more frequently than we might imagine. The scenario: a 6-year-old child arrives at the ER with a clear presentation of complicated acute appendicitis, already evolving into peritonitis. The fever is high, the pain is intense, and the clinical signs are conclusive. The medical team indicates urgent surgery. The conflict. But the parents refuse to authorize the procedure. They are members of a religious community that rejects certain medical interventions, citing doctrinal reasons. They refuse to sign. What can the physician do? Step 1. Dialogue. The first step is to attempt dialogue. To explain the situation and risks clearly and respectfully. It is not about confrontation, but about informing and persuading. Step 2. Institutional protocol. If time permits, the institutional protocol must be activated. Immediately notify the DIF, System for Integral Family Development, the Public Prosecutor's Office, or the competent authorities. These bodies can intervene to protect the minor's right to health. Step 3. The critical action. However, if the prognosis worsens by the minute, if the child enters a critical state, and there is no time to wait for an official response, the medical team can and must act. They proceed under the principle of the best interest of the child, with the backing of another authorized physician, and leave a subsequent record in the file. This is not a decision taken lightly. It is not about overriding the parents out of whim or arrogance. It is about fulfilling a legal and ethical duty. The legal mandate. The Constitution, in Article 4, and the Convention on the Rights of the Child, in Article 3, are clear. The well-being of the minor must prevail over any other consideration. When a child's life or integrity is in danger, the state and its institutions must act to protect them. Further study. In the book, these types of cases are analyzed in greater depth, including specific scenarios, criteria, and practical recommendations for proper institutional management. Up to this point, we have discussed when and how therapeutic privilege can be applied. But now, it is fundamental that we pause to strictly define its limits. Therapeutic privilege is not a license to act without consent whenever one pleases. It is an extraordinary measure, not a habitual resource, and its misuse can have severe consequences. First, from an ethical standpoint, acting without consent in a situation that does not strictly justify it constitutes a direct violation of patient autonomy. Even if the intentions are good, bypassing consent can easily turn into a form of undue paternalism. Second, from a legal standpoint, a physician acting without real justification can face administrative, civil, or even criminal liability. If the procedure was not truly urgent, if there were alternatives, or if it was not adequately documented, a legal defense becomes virtually impossible. There is also an institutional risk. The abuse of this concept erodes the trust between healthcare staff and patients or their families. This breach of trust is the breeding ground for conflicts, formal complaints, and lawsuits. Therefore, we must remember, therapeutic privilege cannot be applied in elective procedures, nor simply when obtaining consent feels uncomfortable or difficult. Furthermore, it must never be used as an excuse for a lack of organization or time constraints. And finally, a critical reminder: acting without prior consent never exempts the physician from the obligation to document the event afterwards. The clinical record is the only tool capable of proving the context, the medical criteria used, and compliance with the law. To avoid errors, confusion, or even legal consequences, it is fundamental that the use of therapeutic privilege be governed by clinical, ethical, and institutional best practices. First, assess and document the urgency. It is not enough to merely perceive a risk. You must place on record the clinical signs, the data supporting that urgency, and exactly why it was determined that there was no time to obtain consent. Second, consult with another authorized physician. Even if there is no time to convene a full medical board, the backing of a colleague validates the decision. This also protects the professional intervening and reinforces the transparency of the action. Third, act immediately only when life or health is at risk. If there is a possibility to wait, or if the situation is not critical, the regular informed consent procedure must be followed. Fourth, once the patient is stabilized, document everything rigorously. This includes who made the decision, at what time, with whose backing, what procedure was performed, and what the outcome was. The quality of this record is key to your legal defense. Fifth, in complex cases or those involving minors, notify competent authorities. If time permits, securing support from the DIF, the public prosecutor, or the bioethics committee can provide greater legal and institutional backing. And sixth, avoid repeated or mechanical use. If therapeutic privilege becomes a common practice, it is a signal that the system suffers from structural failures regarding how consent is obtained or how clinical work is organized. Final reflection. This privilege must be exercised with seriousness, ethics, and prudence. Because in the end, it is not just a legal tool. It is a profound decision that touches a person's life, their body, their rights, and their trust in medicine. A note on the book. In the accompanying book, you will find a comparative table distinguishing between the correct and incorrect use of therapeutic privilege, as well as practical examples designed to help you identify borderline situations and handle them responsibly. Therapeutic privilege is one of those concepts that reminds us that medicine is not just science, technique, or protocols. It is also ethics, responsibility, and humanity. Acting without consent is an exception, yet there are moments when doing so is necessary to save a life. Moments where waiting for a signature, a phone call, or an authorization could mean losing that life. That is where this concept comes in, not as a license to decide for others, but as a mechanism to protect them when they cannot decide for themselves. However, its use demands a great deal from the physician. It demands clinical judgment, it demands balance, and above all, it demands conscience. Because knowing what the law allows is not enough. You must know when to apply it, how to execute it, and how to demonstrate that it was the right decision. A note on scope. The examples we reviewed today are merely sketches. They serve to introduce the topic, but they should not be taken as definitive guides for every real-world scenario. Every clinical situation is unique, and every decision, especially involving therapeutic privilege, must be grounded in evidence, ethics, and regulatory backing. For deeper study, in the book, The Art of Medicine Within the Framework of the Law, you will find more documented examples in greater detail. It delves deeper into the legal foundations, ethical criteria, and specific institutional scenarios where this concept applies. As students and future professionals, always remember this. When there is no time to ask for permission, there must still be time to decide correctly, and afterwards, the time to explain, with clarity and honesty, why we did what we did.